So thank you to the organizers for inviting me to give this talk, specifically around COVID-19 in children, around schools and daycare, and giving our experiences from the South African perspective, where we advise the South African government around this issue of return of schools, reopening of schools. One of the things was that developing COVID-19 guidelines was really around like building a plane while flying it. And some of the lessons that we learned as we went along was that you needed to acknowledge the evolving nature of evidence, frequently review the guidance and respond to new evidence that became available as time moved along, and be willing to adapt and change the guidance based on new evidence. And also be able to rigorously have a scientific evaluation of the evidence, especially where there's several different publications that are in the public domain that are either preprint or have not been evaluated as yet. And in the absence of evidence, really base your decisions on basic scientific principles that guide the guidance around these interventions. And the basic premise is really around keeping children safe, especially in these uncertain times where there's several different indications in terms of what parents and educators should do, whether they should close schools, reopen, and these can be extremely confusing and scary both for parents, educators, but also for the children themselves. And the major thing is around weighing the risks versus benefits of opening schools. And the major risk is around the transmission of SARS-CoV-2 within schools. And as we heard from Lynn, is that there appears to be a lower risk of SARS-CoV-2 infection in children compared to adults. There's a much lower risk of infection, COVID-19 related deaths in children. And there's a decreased prevalence of comorbidities like hypertension and diabetes that increases the risk of severe COVID-19 in children. The likelihood of transmission is still a question mark, but there appears to be a lower risk of transmission, especially in very young children. And there's really a question mark around what children play in terms of the contribution to outbreaks within schools, but also within the general environment. And the benefit side, I think education is a major area in terms of the benefits of reopening schools, while distance learning and online learning may be a major portal available, but this needs access to computers, electricity, and internet, which is not widely available to many individuals within the world. And this disproportionately affects vulnerable families and children and communities who don't have access to these facilities. And the fear is that this may make the disruption within the disparity within society even greater. In addition, there's some collateral damage in terms of social isolation, mental well-being, child protection, and cognitive development that occurs as a result to closing of schools. In addition, school nutritional support, and in South Africa itself, about 9.6 million learners receive a daily meal at school. And a recent survey reported that at the start of the COVID-19 epidemic, about 1 in 7 people surveyed had a child who went hungry in the household in the past week, and about 6 million of our 20 million children live in households with no employed adult. With approximately 1/3, which is about 6.4 million children, living in households where families live below the income poverty line. And the context is extremely important versus rural schools that are poorly resourced versus urban schools which have many more resources, both for distance learning but also risk mitigation. So if you look at school closures over the time, so from June when we started developing these guidelines, there was about 1.2 billion students that were out of schools. And certainly if you look at this map, majority of countries had schools either completely closed or had localized closures within schools. cut to 2020, now majority of the world has actually reopened the schools to a large extent, either completely or have partial reopening of schools. And certainly the question really becomes not really around reopening of schools, but really how do we maintain schools open and how do we maintain it being safe for children and educators to learn in. And if you look at the epidemic, both in France and Norway, the reopening of schools really didn't make any difference in terms of the overall epidemic. In South Africa, we looked at our numbers in terms of both the in-hospital admissions, but also the laboratory-confirmed infections in the country itself. So in South Africa, we closed our schools during the peak of the epidemic, and we started reopening the schools early late in July. By the 3rd of August, all schools and all children returned to school. And really, if you look at these numbers in terms of the laboratory confirmed cases, there was really no major impact in terms of the reopening of schools, in terms of the numbers of children infected. And the line at the bottom reflects the numbers of children. And you can see that the curve in children really mirrors the curve within adults, showing that much of the infection that occurs in children are a reflection of community spread outside of the school environment. In addition, we had sentinel hospital-based surveillance, which again showed the similar sort of numbers in terms of the infections. And adolescents over 15 to 19 had the highest risk of admission to hospital for SARS-CoV-2. And we looked at several countries in terms of their response to it. So Sweden had an open school policy where they kept children and students who are sick at home, raised awareness of hand hygiene, extra cleaning, social distancing, and maintaining outdoor activities as much as possible. And at the end of it, if you look at the seroprevalence of infection in Sweden versus Netherlands, which closed their schools, the proportion of adults versus children that were infected are pretty much the same, really showing that the reopening of or maintaining the schools open really made no difference in terms of the infections in children. And then we looked at several country reports of infections or outbreaks that occurred within these countries. So this report from Australia looked at several different outbreaks that occur. And the major point was around that, as highlighted in yellow to red, is that the transmission from staff member to staff member was 4.4%, whereas the transmission from child to child was 0.3%. So majority of transmissions seem to occur within staff members as opposed to between children. Similarly, in Singapore, they looked at 3 different outbreaks, one in a secondary school and 2 in preschools. And in the last 2, there were no secondary infections from exposures to an infected individual within the school environment. In this report from England, where they looked at multiple cases and clusters, and again, if you look at the probability and the direction of transmission, majority of the transmission occurred from staff to staff, whereas the risk of transmission from student to student was the lowest in terms of the ranking. In France, these reports again show there's lower risk of transmission from staff to children, whereas the majority of these occurred within teachers and non-teaching staff within the school. In Ireland, in this outbreak where there was 6 cases that were found, and about 1,000 children were traced, there were no confirmed secondary cases of COVID-19. So there were several limitations to these studies. Certainly, the sample size is an issue, and the inclusion of only symptomatic patients for testing, which may not reflect the full spectrum of SARS-CoV-2 infection, especially in asymptomatic presentations, which are more frequent in children. The other issue that we found was that there was very little description of what factors they put into place in terms of preventing transmission in the schools, and what are the risk mitigation strategies that they put into place. So the bottom line is that SARS-CoV-2 infections will occur within schools. Infections in children reflect the extent of transmission within the community. Majority of school-going children are infected at home. Staff in schools, both educators and non-educators, will have a similar probability of becoming infected as in the community, especially as society opens up and potential transmission events occur. And the really area is around risk mitigation within that environment. So what we looked at is, in terms of general infection prevention control strategies, which include engineering controls, administrative controls, and the use of personal protective equipment. And the engineering controls included ventilation, space for physical distancing, water and sanitation, administrative controls around implementation and monitoring of social distancing guidelines, hand hygiene, and the frequency of cleaning, and also screening and limiting the entry of individuals into school environment, and the appropriate use of personal protective equipment, which includes in that environment cloth face masks as we recommended in South Africa, and the appropriate use of face shields. And really around cloth face masks, there's very limited evidence in terms of the use of these devices to protect infection. However, if you look at some of the data around the use of face masks for protecting against seasonal flu, there's some evidence that it works. It works better in older children who are able to maintain and keep their mask on for a longer duration of time. The major areas that we of difficulty, especially in hot, humid climates, there may be irritation from the mask, breathing difficulties, discomfort. Children may become distracted, and especially where there's low social acceptability or a poor fit from the mask. So you really need to work with the society or the school environment in order to get buy-in in terms of use of masks within that environment. The other area that we felt we had to add some guidance on was around evaluating potentially harmful practices, one of which was the use of spray tunnels. Many of them had chlorine-based disinfectant, which were found to cause respiratory and skin problems and eye irritation, and we advised that this be avoided entirely in children. In addition, the use of environmental spraying, fogging, and fumigation in the environment, again, had no demonstrated impact on terms of the transmission of SARS-CoV-2, but also many of the chemicals used remained on surfaces that children had exposure to and could potentially be harmful for children. And in addition, we had to develop specific guidance around management of an infection of SARS-CoV-2 infection within schools, and provide it in as easy a format as possible so that it could be implemented in a system that really wasn't designed around the management of a pandemic in the school environment. So finally, education is a basic right of all children. The pandemic is with us for the next few years. We know that children have usually no or very mild features of COVID-19 and may be less likely to transmit the virus. We certainly need to protect students and staff who are at the highest risk of severe COVID-19 infections, who have comorbidities. But again, with risk mitigation interventions that are put into place, we can control the spread and prevent the spread of infections within schools. Certainly, there's a need for more research on transmission of SARS-CoV-2 in schools and the environment, the evidence base around interventions to control the spread. So to leave with a quote from Nelson Mandela, that education is the most powerful weapon that we can use to change the world, and we need to do that in a responsible way. And finally, some acknowledgements to the other members of the South African Ministerial Advisory Committee on COVID-19 and the Medical Research Council of South Africa. So thank you.